Okay, can you hear me well? Okay, so first of all, I want to thank David for giving me the opportunity to present my work today. I'm very glad. Thank you very much. I think it's very important for me to be a bit more visible in the community, and I think it's timely. Just for the joke, he asked me whether I would have something ready to present for today. He asked me that on March. I answered yes, of course. And the result that I will show today, well, we did get that 1 week ago. And so they are a bit fresh. So I have 3 parts in my talk, and maybe it can be a bit frustrating because I will go fast on some aspects. The idea is to, initiate question and discussion that we will have at the end of my talk all together. And okay, so first of all, I want to thank my collaborators to introduce them. So as you see, as I will show, managing clinical data is quite a challenge, and so this would not have been possible without these guys. So you have on the left the colleagues from the Institut de Neurosciences de la Timone, so including Julien, we are in the same team, and François Rousseau from Brest. On the right side, you have the medical doctors. You will understand better. I know you're aware of that, but how precious and important they are in this process. And in between us, you have the PhD students, engineers, and postdocs who have to deal with all these guys. What is important is that we have to work really in a collaborative manner, very intricate, and I hope that I will illustrate that, and you will understand how important it is just by looking at the stuff. So I will start with this study that I guess you're aware of, which, in my opinion, is a major step towards translation into clinical routine and clinical picture. Because, well, you see the sample size, more than 100,000 MRI that were combined in order to generate this normative curve that you see at the bottom. So at the bottom of the normative curves, and at the top you see the data across all these subjects, and they span this impressive age range from almost 100 days of gestational age to 100 years old, so all lifespan. And so this is very impressive, but what I want to show more precisely today is that, so if you zoom in around birth, which, as Jeff did mention earlier, is a critical event, you see that in the data, well, it's a bit of a mess. Well, there are some sort of discontinuity. There is not the continuity that we would expect to see when you look at the curves. Okay, so basically, in this kind of study, you estimate a continuous curve based on your data, so you are imposing the continuity. Okay, and so here you see from the data that, well, this continuity assumption is a bit arguable, and basically I will show with our data how we can complement this and discuss further this point. So I will divide my talk in 3 parts. First, I will explain you what we can do with clinical MRI that were acquired in La Timone since more than 10 years. So what we can do when you have access to clinical MRIs, but also precious time of clinicians. Then I will explain how we did benefit from recent deep learning techniques and public data that Serena did introduce this morning, the DHCP. This was really critical for us to process our data. And then I will shortly show what we do in terms of computational anatomy. So let's start with that. So here, the aim was simply to process more than 1,500 fetal cerebral MRIs that were acquired in clinical setting. Okay, so to do that, that's where you need not only, if you have access to clinical MRI, it's good, but really with that, you will be limited very, very fast. Here, really, the challenge was to get most of this data. So it took actually more than 10 years. Okay, it was this work was initially it was initiated by actually Julien and Nadine. They are both present in the room in 2012. Okay, and so let me very briefly mention the few steps that we did with the few challenges that we faced. First, legal aspects, one line, but 3 years of effort. Okay, I do not enter into that, but you know. Here is maybe more interesting. Maybe something that was original here was this loop that we did build all together. Since the beginning, the aim was to get the best of the data. So for that, you need to go back to have time to discuss with not only the neuroradiologist, but also the pediatric neurology department and the obstetrics. And in order to do that, it takes like 20 minutes per case on average. If you do that from scratch, it's very difficult. So here the idea that we did first access to the MRI data so that we could do some quality check and set up a prioritization of this interaction with the medical doctor. And I will exemplify that later. Ultimately, it has been already mentioned earlier, the goal, the level that we would like to reach would be to have also postnatal assessment of the development of the fetuses. And I don't have time to enter into that, but we have a plan and we even have a funding for that. So we will call back basically all the families of the fetuses that have no abnormal findings at MRI in order to assess whether or not they are developing normally. So here is the first visualization of that data set. At the bottom left, you see just for comparison the few recent studies with sample size. You see the order of 300 for the best study with best sample size. On the right, you see one view on this data set, so a bit more than 1,050 clinical exams. On the top of that, the medical doctors and the engineers will validate more than 1,000. Okay, you can make the multiplication with 20 minutes per case, and you get the number of hours and days that we did spend on that. And with that, we have this first level of classification, so more than 300 cases for which we consider as normal. So here I cannot enter into what we call normal. Here I leave that for discussion afterwards, but we consider some of them as normal. We have a bit more than 150 with ventriculomegaly, so enlargement that are the ventricles that are larger than 10 millimeters by ultrasound. We have more than 140 with corpus callosum anomaly, not only agenesis, and well, many other pathologies. Of course, the heterogeneity here is both the strength and the challenge. Let me just give you just another level of description. If we take the ventriculomegaly, we have almost 100 cases for which the ventriculomegaly is transitoire, so which means that at birth there is an assessment of the size of the ventricles, either with a transcranial echography or with a neonatal MRI, and we have almost 100 cases for which actually the size of the ventricles is back to normal. For the corpus callosum anomaly, we have 60 cases where this anomaly is isolated. There is no genetics or other visible anomaly, but there are also other cases where the agenesis then is complete or partial. Well, we have this kind of, hierarchical description of the data for each of the categories. So with that, now the other challenge is to process the imaging data. So here, usually the pipeline is quite similar across all user groups. You start with low resolution images from which you want to get reconstruction, so a 3D high resolution volume that you can then segment, and eventually you want to apply the fancy computational anatomy tools from Jeff, the ones that I will show later. I will go very quickly through this pipeline. The first one is the reconstruction, and here I will be very brief, but we did apply the 3 most recent techniques for the reconstruction, and we have a very low rate of success. Around 50% of the cases only we can get a nice high quality reconstruction, despite the fact that the quality of the 2D images is good. So basically here, in our opinion, we can do better. And so we have actually PhD students working on this particular step. When it works, what do we get? We get this kind of images. So if you zoom in, it's a bit, you see a bit better that the quality of the data. For instance, here you can see variations in the contrast of the white matter, future white matter. So you see variations related to tissue maturation. And you also see that the contrast between tissue is sufficiently good to move to the segmentation. So again, here, from the more than 300 control cases, we end up with 150, a bit more tables. So now let's see what we can do with these guys. Here is an histogram of the age. The one on the left, you see the quality was not so good. We did exclude it, but that's just to show the range of age. And here now, the problem that we are facing is that we want to segment this image. And here, we took a very pragmatic approach. So this morning, Serena Council did present the Bounty approach, which is really complementary, completely different way to do that. On our side, what we did do was to also benefit from the GHCP data. So that's the one on the right. There are MRI data acquired after birth, okay, also preterm, but after birth. Very good quality data acquired not in clinical setting, in research. And in this very nice consortium, they did also release the segmentation. So based on that, thanks to this open data, and thanks to the very recent deep learning techniques, I will not enter into the details here, but briefly, we did train a model on the 50 youngest subjects from the DHCP, 50 youngest neonates. We did predict the segmentation for all our fetuses, and across all these fetuses, we did select the seven fetuses for which the manual correction was less ambiguous and easier. And just with that, we did fine-tune the model. We saw only 7, and we get this kind of result. So here, what is important is that then, contrary to the study from Bethlehem at the beginning, here we have really had the same nomenclature, the same tools that were applied to all our data, both before birth and after. Here I had one slide on the normative modeling, but thanks to Serena and Jeff, you know what it's about. So let me switch directly to the red. So here now we have this normative model that were estimated from a combination of neonatal, postnatal, and antenatal babies, 600 data points. And you see, for all these structures, how continuous the curves are. Okay? For instance, for the cerebellum, I like it a lot, very, very smooth. There are some a bit more curved here trajectory, but basically, it is very, very different from the data that were shown in the original paper from the event. So for the shorter saga, so really that's the same feature, okay, that we look at, and clearly we don't see this here. Basically, we see the different data sets that were processed using different tools. Okay, so what we observe on our side is really a continuum for all the structures. Actually, all the structures except one, which is the external CNRS. So here, same model, same processing, everything similar, same subject. So basically, for this subject, we have this continuity for gray matter and etc. For CSF, we observe that. So here, just on the right, I add the volume normalized by total point volume, just to say that it's not just a problem of total point size. We really have this complex pattern here. And here we can question whether a single model is relevant. Eventually, we would like to fit here two different models. You see, not only the mean trajectory is different, but also the variance. So here for this structure, eventually the change due to birth is so sharp that there is no continuity. And when we look at the whole images, Jeff did already show similar things from the previous study by Julien. When you look at the data, basically, you observe this very strong change in the volume of CSF. So basically, the obstetricians and the neurologists, you are not surprised. There is no surprise here. It's just that, to my knowledge, that's the first time that it is really quantified with this kind of really same tool, same procedure applied to both antenatal and postnatal data. Here, once you have normative curves, the next question is, okay, can you show me the usefulness of that, how you use that in practice? So here, very, very fresh results. I just show you, maybe we will discuss that later. What we observe when we put preterm babies in this pipeline, so that the preterm data from the DHCP, so it was really easy for us to do that. Here is what we observe. We observe a lower volume of CSF before birth, and a higher volume compared to normal babies after birth. Okay, so here, well, let me not comment that. We will go back to that if you have questions later on. And let me switch to advance toward the computational anatomy tools. The first thing that we can do that was not done by the paper of Bethlehem and colleagues was to extend the study with measures of gyrification. So in addition to the volume segmentation, we have the surfacing, and so we can compute the gyrification index. And as was already mentioned also by Jeff, you see surface area, eventually there is a slight change, but not that strong. And when you look at the gyrification index, there is something happening here that is very, very strong. Okay, to my knowledge, also that's the first time that this is quantified. And again, that's based on clinical data. So I was quite fast, and I will not have time to explain you how we did that. I will not enter into the detail in order to keep time for later discussion. But what I want to show you, I think that's the most important slide for me here. These are the subjects that we are in this study. You rarely see that in the studies, either because people would prefer to look at the average subjects, or maybe because the data is not so good looking like this. But here, that's really, to me, the main achievement of this 10 years of work. Here you can see, well, the evolution, the progressive folding. So I did sort this by hand. Okay, there is no visualization, but you see the increase of gyrification with age. Okay, on this axis, but on the other axis, what's more interesting for at least Jeff and me and few other guys here, that we see the emergence of variation across individuals. So at the beginning, the folding pattern are very so simple that they are not that different. And at the end, you have variations that are very similar to what you have in newborns. So here with this data, now we can use the nice tools for computational anatomy and for trying to quantify this qualitative observation. Okay, so I see I have a bit of time. I'm on time so far. So let me continue with computational anatomy tools. So here you will see my aim is both to acknowledge some sort of affiliation with Jeff and his team. We are also working with a descriptor of the folding patterns, and for sure a lot of ideas here come from Jean-François Mangin. But here today the game is to show up a bit the differences. So here what we use are the term that we use is sulcal pits, and the idea behind sulcal pits, the conceptual level, is to divide the sulci into smaller entities. So basically, these are sulcal pits. So we take a brain, we have an estimation of the depth of the fold, and with that, we divide the fold in a smaller entities that we call sulcal basins. And in each sulcal basin, we identify the deepest point, and this is the sulcal. Compare that with the sulci nomenclature from Brenda. So really the type of methods that Jeff presented earlier. Well, you see basically that we are dividing some of these folds, so we have, let's say, a higher spatial resolution in the description of the folding pattern. Why is it so important for us? It's because having these smaller objects is critical because we have access to higher resolution both in space and time. So this is just illustrative, but if we focus on, for example, the supratemporal sulcus, here what you see that, again, this is illustration, we have to confirm that, but what you expect to see is that with sulcal pits, we'll be able to identify, isolate the modification in subparts of sulci. Okay, so an improved level of description both in space and time. Basically, we'll be able to track the formation of a new fold and be able to quantify the evolution, for instance, just by measuring the depth of the sulcal. Very importantly here, I see I'm done in time, so I will be brief. I do the chairman myself. Very importantly, with the sulcal pits, conceptually, these objects are based on a model, which means that without entering into the details, there are assumptions, and so with these tools, we can test several assumptions regarding the patterns of folds at different ages. And so I don't have to enter into the details of all the methods that we develop. Actually, that's my main research topic when I'm not working with clinicians. And so basically, we are developing tools to quantify the evolution with age. Other tools to define spatial correspondence across individuals, which is not trivial. There are different aspects of both the conceptual aspect and the implementation aspects, like for instance, the influence of the size of the brain on the accuracy, the errors that we make in the extraction process. And the biological meaning of the sulcal pit, with several sub-topics. The biomechanical models that mostly the work of Julien, and some works on doing the same stuff with other species, and in particular non-human primates, including fetal MRI in baboons, which will be very interesting in the future. And with that, I'm done. I just finish with this recap of the main things that I did present. And I'm done.